Good morning, everyone. We are going to commence our program this morning, and we'll commence with the picture tests from internal medicine. And Dr. Alimi will continue with he will start the picture tests. So I believe it's ready now.
Yeah. Good
Okay.
morning, everyone. So this morning, we'll continue from where we stopped. I learned we did some clinical examination yesterday, so we'll continue with the picture test today. So next slide, sir. Okay, so let's look at this picture carefully. So what is obvious? So anyone want to try? What is obvious on this chest X-ray? Okay, if it is not obvious, we can look at the options. Maybe we can then put that into perspective. So, and that's where OSCE goes. So if you have a picture test, sometimes the answer may not be so apparent to you. But when you look at the options given, you may then come back and then look for the features expected. Anyone want to give it a try? Okay, no one. So now it's obvious from this HSP that this patient has cardiomegaly. That was one of the first things that we look at. So the second thing is that you see that there is also upper lobe diversion. You see some streaks pointing upward. Well, they are not really streak per se. They are actually blood vessels that are engorged. So that's that. Then the second thing about, let me see where I can't share on this. But let me see whether I can write. Okay. Oh, I was trying to see if I could write on the slide. Okay, sorry. Unfortunately, I can't. Okay, so let's continue. So now, we will also see some streak horizontal streaks or opacities going horizontally. So those are the things that make one suspect that this patient's X-ray is consistent with features of heart failure. So if you look at the options, it says the patient with displayed chest X-ray is likely to present with dyspnea and easy fatigability. So that will be correct. So Kelly B lines are a common sonographic finding. Well, not that we can find it on what was it called, on ultrasound, but it's better seen on chest X-ray. So that option will be incorrect. Now the next one, the condition can occur as a complication of ischemic heart disease. So definitely, so ischemic heart disease can also present with heart failure. Anything that affects the functioning of the heart, whether it is the mechanical part of the heart, that is the heart muscles, or the electrical conduction system. So all those can give heart failure. So the gold standard for making a diagnosis is echocardiography. Well, while the diagnosis is still clinical, so but if you want to talk about just one single investigation, Then you talk of echocardiography. But even as at that, we also know that there can also be heart failure with normal ejection fraction. So we should be mindful of that. So ACE inhibitors and ARB are agents known to lower mortality in this condition. So that's also correct. So for this exam, it is expected of us that we should know those drugs that will reduce mortality in heart failure. And we should know drugs that will only reduce morbidity. For instance, the patient with heart failure comes in with breathlessness. So, and we give diuretics. So that diuretics will only help remove the fluid from the lungs and probably from the abdomen if the patient has ascites. So that will only improve the morbidity, but it doesn't have anything to do with the mortality of the patient over time. Okay, but there are some drugs that when you give, they are the ones that improve the mortality of this patient. And some of those drugs include ACE inhibitors and ARBs. That's A. B is beta blockers. Okay, so there are some other drugs like what was it called now? Uperil. So sacubitril valsartan combination. So that will also improve mortality. So newer agents like the SGLT2 inhibitors, those ones too will also improve mortality in patients with heart failure. But out of all these things, two drugs that we should know will only improve morbidity. So number one, diuretics. Number two is the digoxin. So we should be aware of those two. Those ones will only improve morbidity and not necessarily reduce the mortality in patients with heart failure. Can we go to the next slide, sir? Okay, so now let's look at this question number 2. So when it comes to ECG, you have to be a bit systematic in looking at the ECG. Okay, so you look at the P wave. So after you look at the P wave, you look at the PR interval. Okay, so once you are done with the PR interval, if it is prolonged, you say the patient has first degree heart block. If it is not prolonged, that's normal. So after that, look for presence of Q wave. Q wave means that after that P, the next wave should be Q. So if there is a deep Q wave, you think of an old infarction. Okay, so once you are done with that, you can also look at the KRS complex itself, the duration. Okay, if the duration is increased, you may start thinking of bundle block branches blocks, which might either be right bundle branch block or left bundle branch block, depending on the configuration. But for this ECG, if you look at it closely, you see that lead 2, 3, and ABF, their ST segment is elevated in those areas. So that will still not be enough to say that patient has myocardial infarction, ST segment elevation, myocardial infarction, STEMI. You now look at also what we call the contiguous lead, or don't let me say contiguous. I can't seem to remember the name to call it now. So reciprocal, yeah. So if you look for the reciprocal leads for reciprocal changes. So the leads where you are going to look for those reciprocal changes are the lateral leads. And the lateral leads are lead 1 and AVL. So if you look at lead 1 and AVL, you will see that what you have there is ST segment depression. So in the inferior lead, when you have ST segment elevation, and in the reciprocal lead, when you have depression, so that is consistent with myocardial infarction. And so this patient will be treated as such. Now, to confirm, ECG alone will not make you make that diagnosis, but it gives you that suspicion. So to confirm, you may also need to do the troponins. So serial troponin. So if you demonstrate that the troponins are increasing, then you can almost say that this patient has myocardial infarction. At least for exam, once you see this ECG, it is MI, inferior lead MI. So now the options. Clinical presentation is that of substernal diffuse pressure like chest pain radiating to the jaw. So that's correct. So the patient is likely to respond completely to treatment with nitroglycerin. That is not correct. The reason being that you can use this to treat stable angina. But when it comes to acute coronary syndrome, and when we say acute coronary syndrome, there are three things there. Unstable angina, that's one. Non-earth segment elevation myocardial infarction, that is two. And the third one is what we are seeing here, earth segment elevation myocardial infarction. So what's the difference between these three? Because they can ask. Unstable angina, the patient is having typical chest pain, but you have done ECG, nothing significant on the ECG. You have done troponin, is also normal, but you strongly suspect that this patient may be having some form of myocardial injury. So that will be unstable angina. The second one is NSTEMI. So there's non-earth segment elevation. So the earth segment is not elevated. But one evidence that you have is that the troponins, they are rising. Why are they rising? Because anytime you lose a cell, a myocardial cell, it's going to release the protein inside it into the cytoplasm, and that can also split into the blood. And therefore, the enzyme will go up. So if the enzyme is only going up, and then the ECG is not showing ST segment elevation, so you say that that is NSTEMI. And for STEMI, both the enzyme elevated as well as the S segment is also elevated. So nitroglycerin is not a drug that you want to use in this patient because it may reduce their chest pain, but it will not take out what is wrong with them. So history of stroke within the last 3 months is not a contraindication for thrombolytic therapy. So well, that option is a bit doubtful because some of the contraindication to thrombolytic therapy is that if the patient has suffered stroke for over 3 months, so if it's still within, maybe you can still give for after 3 months, you probably want to wait and see. Okay, so we should actually check that up. So I think it's a contraindication that if it's after 3 months, you may not need to thrombolyze because the risk of bleeding. So you can convert an ischemic stroke to an hemorrhagic, what we call hemorrhagic conversion. So we probably not want to give a thrombolytic therapy. So for the option D, patient will present within symptoms, 24 hours of the onset of symptoms, should have the perfusion strategy. So yes. So if the patient comes within 24 hours, so if it is a place where you can do what we call PCI, you quickly want to do that. But if you cannot do PCI, then if the patient presents within, for the arts now, we said the presentation is 4.5 hours, so you give out a place. But here, the timing is a bit different. So if the patient presents within 12 hours and you don't have facility for PCI, you can still give outer place, the nectar place, or any of those other options, streptokinase, all of them can be given here. But for the stroke, it is strictly outer place. Okay, so essentially what you should just know here is that perfusion strategies come in two flavors. It's either you give the thrombolytic therapy or you simply go for your percutaneous coronary intervention, and there are timing to all this. So next slide, sir. Please, I want feedback. Nobody is talking. Question number 3. So what can we see here? So now I won't talk. I want somebody to talk. What is happening? Dr. Bello, can you please help us out with this picture?
Good morning.
Good morning.
Clubbing, sir.
Clubbing. Well, you've tried, but if you look closely, for clubbing, it should be raised. It should be raised. So clubbing means that you have bubble swelling. What? So this looks like spoon. So when you have a spoon, you have a kind of depression in the center. So you can see that there's a depression here.
So it's conicia.
Exactly. So spoon-shaped nails. The nails appear spoon-shaped, and that's what is called koilonychia. And it's typically seen in iron deficiency.
Anemia.
Yes, so, exactly. So let's look at the options. Average daily iron is 1 milligram per day in men. That is correct. So of course, the body does not really have a well-regulated way of losing iron. So an average man would lose about 1 milligram per day in stool. So that means that you only need 1 milligram per day to replace that loss. But a woman loses blood every month through menstrual flow. So therefore, they will require more than what a man would need. So that's why they require 2 to 3 milligrams per day. So commonest cause is blood loss. Well, we'll still take that, but in our own environment, most people have iron deficiency anemia, and the commonest cause is actually nutritional. But it's fine, we'll take that option. Option C, low levels of ferritin and ITIBC is diagnosed. Correct. Now, ferritin, that detects iron stores. So if ferritin is low, it means that you don't have enough iron storage. Because somebody developed iron deficiency anemia, the body will have used up all the storage form of iron. So when you have used up all the storage form of iron, then the next thing that you then see is that the person will then present with features consistent with iron deficiency anemia. Now, total iron binding capacity. So that means that in the plasma, there is something that carries iron, the transferrin. Okay, so if transferrin is not having any iron attached to it, that means that the capacity of transferrin to carry iron is high, because why? It doesn't have iron attached. So therefore, you need more iron. So the only thing that probably goes up in iron deficiency anemia is this total iron binding capacity. So the option D, blood film is that of macrocytic hyperchromic anemia. So that's false. So it should be
Microcytic hypochromic.
Exactly. So that's the one that is odd in that option. So question number 4. All right. So now, who is going to volunteer for this case? This is a straightforward case. So maybe because I'm in GIT. So let me see who to call. Anybody want to volunteer? Yes, ascites. Yes. So which option do you think is not correct here?
Portal hypertension is rarely seen in such patients.
Exactly. So that's the odd one out. So in a patient that we suspect has liver disease and present with ascites, once there is ascites in the patient with liver disease, so you must think of portal hypertension. Why? The reason for that is because if you look at the portal vein, anatomy of the portal vein, it is formed by 2 vessels, the splenic vein and the superior mesenteric vein. Okay? It is the combination of these 2 that forms the portal vein. So if there is portal hypertension, so that means that blood cannot flow through the portal vein, and so therefore it backs down. So that means that the blood will go back to the spleen and cause splenomegaly. So you won't be surprised that patient with portal hypertension will have splenomegaly. The same thing, that blood that is supposed to pass through superior mesenteric vein back into the portal vein will also back down into the superior mesenteric vein. And the superior mesenteric vein also covers the guts. So now there will be increased hydrostatic pressure, and that will lead to water oozing out from the superior mesenteric vein back into the peritoneum. And that is what is responsible for the ascites. Now, option A, possible causes include infection and aflatoxin. Yes. So the infection we are talking about here in this environment, commonest is hepatitis B. Okay. Aflatoxin, yes. So from thoroughly stored grains like granules, and that's why in GIC clinic, we will tell most of the patients to probably reduce their granule to avoid granule that is not properly cared for. So smoking, alcohol injection, and hepatotoxic drug, well, they are all risk factors and can make the liver to become decompensated. Okay, so we've talked about C, that one is false. John is a likely complication, so that is also correct. So let's go to the next question. All right, so now this one is also a simple one. So anybody want to try? Nobody wants to try, so let me look for me. Dr. Ariro, can you try? I hope I got the pronunciation correctly. Otherwise, the person will not even answer me.
I think B.
Okay, B, yeah. So now we can see that this patient is holding inhaler. So in the OSCE, maybe when we have time, we can actually practice how to use the inhaler, because they may ask that, okay, teach this patient on how to use the inhaler. Okay, so now emotional stress might, family issue of atopy are some of the triggers, yes. So we think we may have asthma, yes. So attack more than one day, more than one attack per day. So anything more than one is already moderate, so it's not going to be mild intermittent. So daily attacks that affect routine activity are considered moderate persistent. Well, that's correct. Now, corticosteroids are the most effective in terms of prevention of attacks. So that's also correct. In fact, when it comes to management of asthma, you will not just tell your patient to just be using salbutamol. All of them must have steroid-containing inhaler, meter dose inhaler. All of them must have that, and they must use it on a daily basis if possible, until you are able to wean them off. In fact, they will say that don't even wean them off. Let them have the minimum dose possible. So even if it's just once per day. So those are the things that will prevent them from coming down with attack. Okay, so next slide. All right, so anyone? Oh yeah, anyone. So let me call someone then. Dr. Mariam. Okay, Dr. Yusuf, please go ahead.
Well, I think regarding these questions, actually they are doing Mantoux test.
Exactly. So this is Mantoux test. So which option is not correct here?
I think it's the B. Test
Exactly.
demonstrated a diagnosis test, yes.
Yeah, so it's not a diagnostic test. It just tells us that the patient has been exposed, that's all. So it can't be used for the sole purpose of diagnosis. It only tells us that this patient has been exposed. So the condition is caused by an acid-fast bacilli, yes, which is Mycobacterium tuberculosis. So we've talked about B is wrong. So C, chronic cough, weight loss, drenching night sweat, should be drenching, sorry, about the typo, are common symptoms. So yes. So an induration of more than 15 millimeter in an individual with no risk factor is highly suggestive of infection. So that's also correct. So we have the 5-10 rule. So if a patient is immunocompromised, for instance, the patient who has HIV, the patient with corticosteroids. So for whatever reason, patient is immunocompromised. So the cutoff for that patient will be 5. So if a patient has risk factor for TB, like us now, doctors working with patients with TB, so the cutoff for those kind of category will be 10. Even patients that are in the prison, okay, so their own cutoff will be 10 because they have risk factor to have TB. But if there is no any risk factor, okay, maybe the president, for instance, is not exposed to anyone, he's just sitting in Apple work, enjoying his life. So we'll use cutoff of 15 for him. All right, next slide. So, which of the following is not a complication to the use of the displayed image? So, what image has been displayed here? Anyone?
E.
Yeah, so E. So, this is just simply insulin needle.
Yes.
Okay, so all the other options here are correct except E. It has something to do with the level of glycemia. So, next slide. All right, so anyone want to attempt this?
Option E.
Option E, yeah. So there's a giveaway in this question, and the giveaway is that it is worse at night. So when you see a rash involving the hand, involving the webs of the hands, okay, involving the genitalia, and they say it is worse at night, it's most likely scabies they are trying to make you think of. And if you look at the picture carefully, you see where the arrow is. So where that arrow is, they can actually ask you that what classic sign does that show? So it's actually show what we call burrow. Okay, so the what is it called now? The pathogen as called as burrowed, so kind of thing. So that's what it's called burrowing. So you should note that that is also classic of scabies. So next slide. All right, so this is simple and straightforward. What is the diagnosis here?
Systemic lupus erythematosus.
Exactly. So once you see malar rash, at least for the purpose of this exam, answer is SLE, an autoimmune disease that typically affects females in a ratio of 9:1. And when it comes to its clinical presentation, it can involve the skin, the kidneys, the hematological system, even the CNS can be affected. And when it comes to treatment, so we can use steroid or steroid sparing agents. So essentially in this environment, the patient has SLE, there are 3 agents that we give them. Okay, so we give them hydroxychloroquine, azathioprine, and prednisolone. Okay, so next slide.
Okay, sir. Regarding the SLE, sir, I'm sorry.
Yes,
Why is it this anti-nuclear antibody is the definitive diagnosis?
why is it that
Anti-nuclear,
antibody?
yes.
Why is it that what? I didn't get that. I just
Why?
saw
Why? Yes. Why is it that is the gold standard for the SLE? Gold standard investigation.
Well, it's not as if it's the gold standard.
Okay.
What's ANA, anti-nuclear antibody? What you have in SLE is that virtually all patients with SLE will have ANA positive. But being ANA positive doesn't mean that it's SLE. Other things can also cause ANA to be high. Even TB can cause ANA to be high. Syphilis can cause ANA to be high. So, but when it comes to diagnostic criteria, the first thing that you must do is ANA. So if ANA is there, you will now go for other more specific antibodies. But in terms of the one that is more specific, the answer is actually anti-Smith. So S for specific, S for Smith. So more specific is anti-Smith. But if they tell you which one will you use to screen for SLE, that patient does not have money, you don't want to waste patient money, you just want to do one. So you first do ANA. Okay? Because if ANA is negative, it means that the patient does not likely have SLE. Think of other things. So next slide, sir.
Sorry, doctor, question. So for this question that asked more specific, should we take the anti-Smith?
Specific. If the question says most specific, you go for anti-Smith. If the question says most sensitive, you pick ANA. Is that clear?
Okay, thank you. Thank you.
Yeah.
Mhm.
Next slide. Thank you, sir. All right, so what can we see here? So anyone?
Arthritis, rheumatoid.
Rheumatoid arthritis, yes. So remember when I was telling you guys the other time that when it comes to rheumatoid arthritis, just say RAP MC. The P is PIP. And as you can see here, the PIP joints, they are swollen. They are all swollen. Proximal interphalangeal joint, swollen. And the distal is normal. So giving this kind of sausage appearance of the fingers. Okay? So it is a chronic inflammatory autoimmune disease involving the synovium of joints. So that's correct. So it can have extra articular manifestation. That's also correct. Morning stiffness that improves as the day progresses characteristics. That's also correct. In fact, anytime you have an inflammatory arthropathy, that is what typically happens. So there is stiffness, and then as the patient uses the hand or the limb, it improves. So it commonly involves the joints of the hand, that is the PIP joint, and the metacarpal phalangeal joint. So that's also correct. So meaning that all the options here are correct. Next slide. Next slide, sir.
Yes, this is the next slide.
Okay. So now, yes, somebody said finger clubbing the other time. So this is now, yes. So you can see here that there is a bulbous swelling of the nail bed. Unlike that other one, where you add a spoon-shaped nail. So what's the likely answer here?
Likely answer is E.
Exactly, because all the options listed can actually cause finger clubbing. Bronchiectasis, yes. Ulcerative colitis, infective endocarditis, bronchogenic carcinoma. So all those can cause finger clubbing. Next slide, sir. Number 13.
Which other?
All right. So who is going to answer this one for us? Straightforward and simple.
B.
Exactly. So when it comes to pitting pedal edema, the things that you think of are things that will cause hypoalbuminemia. Hypoalbuminemia. In this case, you can see that chronic liver disease can cause hypoalbuminemia. Nephrotic syndrome can cause hypoalbuminemia. Kwashiorkor can cause hypoalbuminemia. And when you also have reduced oncotic pressure due to hypoalbuminemia anyway, you can have pitting pedal edema. Again, we also know that patients with heart failure, they also have pitting pedal edema. So the odd one here is deep venous thrombosis. So next slide, sir. All right. So who is attempting this? What can we see on the nail bed?
Splinter hemorrhage.
Exactly. So splinter hemorrhage. So in which condition do we see splinter hemorrhages?
Infective endocarditis.
Correct. So that's the correct answer. So infective endocarditis. So next slide. All right. So now let's look at this closely. What is the deformity here?
Swan neck.
Swan neck
Yeah.
deformity.
Swan neck deformity. Yes. So you can see that the flexion is at the distal, what is it called now? PIP joint. So if the flexion is at the proximal interphalangeal joint, we call it proteus deformity. Okay. So, but the Aberdeen node and Bocha node that we were talking about, you see this one in what is it called now? Trying to remember the name of this condition now. Osteoarthritis, yeah. Osteoarthritis. Okay, so next slide. Okay. So what do we have here? Anyone?
Foreign body.
Exactly. So there's something that appear like a coin, close to the hilum of the lung. So that's why this is foreign body. Okay, so what's the correct answer here?
That's D.
D, foreign body aspiration. Yeah, so that's the answer. Okay, 16. Okay, I thought you were here, so that was why I paused the other time. So, still the same picture. So, which of the following is not a management option? So, what's the answer to this one? You guys are warming up now. So, when I started the first 3 questions, there was no attempt.
None of the above, maybe.
What?
None of the above.
Yeah, so what's the answer here? So the answer is actually none of the above because all the options listed here are modalities of treatment in patients who have aspirated. So you can do bronchoscopy. So you go to the endoscopy suite. So instead of entering the esophagus like we do in gastroenterology, you enter into the trachea. And until you can see the foreign body, you can assess it, you bring it out through bronchoscopy. So the other option is bronchotomy. So that means that you go and surgically open up the lungs and bring it out. And you can as well do segmental resection. So next slide. So number 18. So we'll see that in this picture, we have more of tension pneumothorax. Okay. You see that the trachea is deviated toward the left side. And you can see where the white arrows are, that the lung is being compressed by the column of hair from the other side. And therefore, it's also pushing the heart towards the left side. So this is consistent with the tension pneumothorax. But the question is not really asking about tension pneumothorax is asking about which of the following is not a part of deadly dozen. This is more of a cardiothoracic question than even medicine question. So, but the right option here is pulmonary contusion. Pulmonary contusion. So let's go to the next slide. So we should look at the other parts of the deadly dozens. Okay, so now this is medicine, back in medicine. So what's the answer here? So you are saying, yeah, so zoster. So once you see vesicles and you see rash in different form, okay, and they are also what do we call it now? Erythematous. So we think of a chickenpox infection. So next slide. So another simple one, won't waste time here. So someone should tell us the answer to this one.
B. Herpes
Yeah.
labialis.
Exactly. So herpes labialis, herpes simplex virus 1 is the etiology. So 23. What's the answer for this? The purple bottle. You should know all this bottle. If they draw the bottle on the table, please pick the bottle and check. The name of the stuff is written on it, so don't do it yourself.
C.
Yeah, so EDTA. So next slide. So now we are back to this. We've done this before. So what's the spot diagnosis?
Rheumatoid arthritis.
Yeah, so rheumatoid arthritis. Yeah, so the deformities that you can see.
One neck deformity.
And I said it the other time that swan neck is involving the distal, there is flexion of the distal PIP, but boutonniere deformity is causing flexion at the what? At the PIP. So those are the two deformities there. So two risk factors for rheumatoid arthritis.
Female gender.
Yes. What else?
Smoking. Smoking.
Exactly. Smoking. Other autoimmune disease too could also be risk factor, but essentially female gender and smoking. Investigations that you will do. We say rheumatoid arthritis, so why not do rheumatoid factor?
Rheumatoid factor.
Yeah, so what else? What else will you do? It's an inflammatory condition. It can also be inflammatory markers.
ESR.
Yes, ESR, CRP. So what else? Of course, you can do X-ray of the joints. So how do we treat these patients? Pharmacological treatments.
NSAIDs, stimulants.
Yes, so we can use NSAID, we can use steroids. We can also use the drugs that we call DMARDs, disease modifying drugs. So, and the typical example that we use here is methotrexate. Okay, so next slide. So now, bottle A. So if you look at the bottle carefully, you see that the name is already written on it. So just look at the bottom of the bottle and you see the name. So A is plain bottle, and what do we use it for?
Blood grouping and cross-matching.
Exactly. So the second one, green. If you look at it very well, you see that they've written, at least if you cannot see everything, you will see lithium and you see maybe EP, lithium heparin bottle. So what do we use that for? What do you use this term heparin for? Nobody is talking now. Yes, EUCR. Even liver function test. Okay. So next bottle. Purple. We've said it before. EDTA. What is it used for?
Full blood count.
Hello. Yes, full blood count. Okay. So how about the last one? The name is written on it too.
Glucose test.
What?
Glucose.
Yeah, it's for glucose, but what's the name?
Fluoride oxalates.
Exactly, fluoride oxalate bottle to check for glucose. Okay, so next slide. Next slide. Next slide, sir. Okay, another simple one. What's the spot diagnosis here?
Vitiligo.
Yeah, correct. So, well, this is more of a social question. At least if you don't know anybody, we know Michael Jackson, the late Michael Jackson. Okay, mention one investigation that you would do. One investigation.
Microscopic exam. Wood light test. Wood light. Wood light.
We can't hear you, sir. Where is Dr. Alimi? We can't hear you. He's muted.
So, hello? Can you hear me, please? Hello?
Yes, we can hear you.
Oh, yeah, I'm so sorry, please. So mention two modalities of treatment. Mention two modalities of treatment for this condition. Oh, sorry, we didn't even do the investigation. So some of the things that you can do for investigating patient with vitiligo, you can do a wood lamp microscopy. Okay, so and the most definitive way to actually make the diagnosis, which we don't routinely do, is to the most thing is actually to do a skin biopsy. So I'm trying to reduce the volume of this CV, but it seems not to be. Okay, let me leave this place. So that's about it. Then for treatments, well, there is really no definitive treatment for vitiligo as of now. So what most people do is that they can probably do camouflage. So they just kind of blend the skin with something artificial. So oh, sorry, the network went off temporarily. So I was talking about the treatment modality. So we can use camouflage. Okay, so in addition to that, we can also give the patient some topical medication, okay, like tacrolimus. In addition to that, then the other treatments, if you can use some some oral medication, such as, how will I even tell you guys now? Okay, let me talk about Prova first. You can also use Prova, and there are some other drugs. Melanocyte can also be given. So those are some of the things that can be used. So next slide, sir. Sorry, I'm taking so much time on because of the calls that I keep receiving. Okay, so this should be simple and straightforward. So anyone?
Picturitis was
Hello?
colon.
Yes, yes. So what can we see here? What is the most, what was it called, obvious thing in this picture?
Hypo and hyperpigmentation.
Yes, that's correct. So next option, next. question. So who wants to attempt this question?
Okay, the clinical indication for dialysis.
Question. So, yeah, so 2 clinical indications.
Okay, sir. Number 1, there is hyperkalemia.
Yes, so what are the other things? All these uremic pericarditis, uremic encephalopathy, uncontrolled hypertension.
Encephalitis, encephalopathy,
Yeah, exactly. So how about biochemical
severe
indications?
metabolic acidosis.
Exactly. So those will still be clinical. Okay, yeah, you can still go for what is it called?
Yes,
Biochemical.
when there is
What are the-
hyperkalemia, when the potassium level is more than 6.
Yeah, yes, when it's more than 6. Aside potassium, what else? How about urea?
Urea, when it is more than 25 millimole per liter.
Correct. How about creatinine?
Creatinine, when it is more than 600 micromole per liter.
Correct. So now there is also another state that we call catabolic state. So in which a patient already has CKD and you've admitted this patient and the potassium was probably 5 before and all of a sudden it went to 6 or it was 4.5 and it went to 5.5. So when you have increase in potassium by 1 or you have increase in urea by 10 millimoles per liter, or you have increase in creatinine by 100 micromole per liter. So this is what we call the 1-10-100 rule. Okay, so 1 for potassium, increase by 1 for potassium, increase by 10 for urea, and increase by 100 for creatinine within 24-hour period. So it's also an indication to dialyze the patient. So yeah, so severe metabolic acidosis will also be a biochemical indication to dialyze the patient. So what are the complications? Complication of dialysis.
Cardiac arrhythmia.
Yes, but which one will the patient suffer from, especially people who have never had dialysis before?
Hemolytic reaction.
Well, yeah, but common things first. You know, you are removing the patient's blood and you are passing it through the tube. So when you do that, you know this mean they already have anemia. So when you do that, what can happen to their blood pressure?
Hypotension.
Yeah, it goes down.
Exactly. So they can have
Hypertension.
hypotension. Yeah. So what else?
CKD.
Well, they already have CKD.
Electrolyte imbalance.
No, that won't be correct. So, you know why it won't be correct? In fact, dialysis is one way in which you can use to correct electrolyte imbalance. So, a patient is having a factory hyponatremia. You just go to the machine and put the setting there. So, if the, what is it called? Sodium is very low. So, increase the sodium of the machine, and sodium will diffuse from the machine into the patient's blood, and it will kind of normalizes it. Not that it cannot cause it, but it can, but maybe not those typical electrolytes, maybe other things like calcium and what have you. So what else? Can they have infections? So, and
Yes.
that's why in UCH here, there is a machine that is used for HIV and patients with hepatitis B and hepatitis C. So those machines is for those that have infectious diseases. And those that are clean, no infection at all, those ones they use other set of machines. So at least those are the complications that we should know. Next slide. All right. So we've done something similar to this. What can we see here?
Ascites.
Exactly. So 2 causes.
Heart failure.
Liver
Yeah.
cirrhosis.
See, when you say anything, heart failure is not a diagnosis. You say heart failure, which may be secondary to this. Maybe secondary to uncontrolled hypertension, ischemic heart disease, valvular disease. So if you now say chronic liver disease, so you can say secondary to chronic HBV infection. So that kind of thing. Don't just stop at that heart failure or chronic liver disease. All those things are not diagnoses. What is causing it, is the main thing. Okay? All right. Mention 2 investigations that you will do for this patient. Oh yeah, what will you do for this patient that has ascites?
Liver function test, abdominal ultrasound.
Yes, so if you think that the problem is from the liver, you can do liver function test. If you think the problem is also from the liver, which test will you want to do if you remove the fluid? If I'm able to get this fluid out, what test would I use it for?
Fluid analysis.
For what? What are you analyzing for? Oh yeah, what are you analyzing for? One is talking. So you can check for MCS. If you think that a patient may have what we call spontaneous bacterial peritonitis, you send it to the lab and they check for organisms. Rarely do we get organism anyway. The second thing, and to even make the diagnosis of SBP, spontaneous bacterial peritonitis, what you actually need is about 250 absolute neutrophil counts from your sample. So if they can look at it and say that, oh, they have up to like 250 per mil or per millimeter, then you can be rest assured that the patient has SBP. So now the other thing that you should actually do is what we call SAG, the serum albumin ascites gradient, or serum ascites albumin gradient rather. So what you do is that you collect the blood, they check the albumin in the blood, you collect the acetic fluid, they check the albumin, and they do the subtraction of the two. Because they can actually ask you, if one of my bosses here is setting question, he like that kind of question. So he will just say, okay, a patient with ascites and stuff, and the SAG is this. So what we call SAG is the serum acetic albumin gradient. So when you do the gradient, if it is more than 1.1, it tells us that there is portal hypertension. Okay, so it's an indication that the problem is likely from the liver. So at least for this exam, so if they say SAG is 1.1, just know that the patient has, if it may be more than 1.1, but if it's less than 1.1, think of other things causing the acetic fluid. Okay, so next slide. Okay, sorry, we are not done. Mention 2 ways of treatment. Two ways. What's happening? There is fluid everywhere. So what will you use to dry out the fluid?
Surgical drainage of the fluid.
Yeah, so you will say surgical now. Just say drainage. Because
Drainage.
surgical will probably know that you want to go and open the abdomen. So what you need
Yes.
to do is just to insert a needle, a gray cannula. So you insert your gray cannula and you drain, you pass it through IV giving sets into a urine bag, and you can drain up to like 5 liters. Okay, if you want to drain more than 5 liters, you will need to give albumin or isoplasma or FFP. You see those things that I mentioned, If you want to drain up to 5 liters, you can drain without anything. But if you are draining more than 5 liters, let's say you want to drain 10 liters, you must give any of those 3 options: albumin, fresh frozen plasma, or isoplasma. And then, of course, you can give diuretics. So if it's due to a liver disease, we combine 2 diuretics. We give spironolactone and furosemide. Okay, so we should mention 2 complications of this. So one of the complications is what I've mentioned earlier, spontaneous bacterial peritonitis. So they can have that. Another complication is that they can actually have hepatic encephalopathy. If they have SBP, they can have hepatic encephalopathy. Another one is electrolyte imbalance. Okay, so if you are retaining water, then we are also likely going to have some kind of electrolyte imbalance. So next slide.
Gaskiya no ne. How busy? No ne.
Good question. If you are not talking, please mute your mic. So cough, dyspnea, chest pain. What can we see on the X-ray? Dr. Hassan.
Pleural effusion.
Which side?
Right-sided.
Exactly. If you just write pleural effusion, you will get 1/2. But if you write a right-sided pleural effusion, you get 2/2. So you see the difference now. And that one mark may be the cutoff. What will decide the cutoff? So don't just say pleural effusion. Please write the side. Okay. Mention the signs in the X-ray.
Meniscus sign.
Exactly. So meniscus sign. So option C. Mention 4 checks examination finding that will be elicited in this case. So you've been taught chest examination yesterday. So what will the patient present with, or what will you see when you examine this patient? You start with inspection until you get to auscultation. At least, even if you say one thing in inspection, one thing in palpation, one thing in auscultation, percussion, and one thing in auscultation. So inspection, what will you see? So the patient may be dyspneic, okay, and the right side may appear flatter or may not be moving as compared to the left side. So that's on inspection.
Decreased chest expansion.
Yeah, so there may be reduced chest expansion on that side. Okay, so that's on palpation. So when you do tactile fremitus, it will be reduced because you have fluid, so it will be reduced tactile fremitus. So when you go to percussion, it will be dull. In fact, if you say stony, if you just say dull, you get 0.5. But if you say dull, if you say dull, rather, you get 0.5. But when you say stony dull, then you get your full mark. Okay, so when you go to auscultation, so if you say absent breath sound, they will mark it for you. If you say fine crepitation, or if you say crepitation, depending on where you are, but mostly what we want to hear is that there is either a reduced breath sound or absent breath sound. Okay? So mention the classification of this condition. How do we classify pleural effusion?
Pleural effusion will either be transudative or exudative.
Exactly. So those are the classification that you should know. You should you should read about light criteria. Okay, so mention 2 causes under each of the following above. So exudative. Mention 2 causes.
Exudative could be pneumonia.
Yeah.
Or tuberculosis.
Exactly. Again, also note that pulmonary embolism can actually present with exudative pleural effusion. Okay. How about transudative? So problem coming from other organ will give you
Like
transudative.
nephrotic syndrome.
Yes, it's coming from the kidney. Like which one again? Heart
Heart
failure.
failure.
Exactly, it's coming from the heart.
Heart failure. Heart failure.
Yes, which other one?
Malnutrition.
Yes. How
Liver
about
cirrhosis.
exactly. So you can see that those problems are coming from other system. So those one will give you transudative. Okay, next slide. All right, so this is data interpretation. So we have a urinalysis of this patient that has type 1 DM. So what is the probable diagnosis here? Type 1 DM, that's the key.
DKA.
Exactly, diabetic ketoacidosis. As you can see here, the ketone here is 3 plus. Okay, so you have glucosuria as well. Protein is just barely 1 plus. Okay, so list all the abnormalities in the results. So I've said glycosuria, ketonuria, proteinuria. So that's 3, and the appearance is even easy. You can write that back for them. Easy appearance is not normal. So well, WBC, some say 0 to 3, so maybe you will not put that as being abnormal. All right, so mention 3 further initial investigations to be done. So you said diabetes ketoacidosis. I want to know the random blood sugar of this patient. So that's 1. Keto. Well, there's ketonuria, but I may also want to quantify the ketone in the plasma by checking for plasma ketones. Acidosis. How will I check for acidosis? So I need to know the pH. How will I get pH? I need arterial blood gas. So in arterial, yes. So this patient can also have electrolyte anemia. So I need to do electrolyuria and creatinine, at least those basic ones. Okay, so mention 3 important management goals.
IV fluids.
Yeah, so you want to correct dehydration by giving IV fluid. So if they say management goals, so you must state the principles. Correct dehydration by giving IV fluid. Because if you just say IV fluid, you get half mark. But when you say correct dehydration by giving IV fluid, you get your full mark. So what is the other principle? The patient has hyperglycemia, so what will you want to do? You want to correct hyperglycemia by giving what will you give for the hyperglycemia?
Insulin.
Insulin and
So by,
potassium.
well, it's only not only with potassium, but it's insulin strictly. It's only when the patient has hypokalemia that you have documented hypokalemia or the potassium is just borderline normal. And you know that insulin can reduce serum potassium. So that may be the only reason why you want to give potassium. Otherwise, what you just is that you give insulin. Okay, so you also say correct electrolyte what? Imbalance. Okay, so those are the 3 major things that you will do for the patient. So other things will include use of anticoagulants because there's risk of having deep venous thrombosis. All right, so next slide, sir. Okay. So who is going to attempt this? Carl. Carl has not spoken since morning, no. Dr. Carl. Okay. Dr. Carl doesn't want to talk. Okay, it's fine. Dr. Memuna. This X-ray itself is looking more of a pediatric patient than an adult patient. But it's okay. So we want to make an
So,
yeah.
so
Yeah.
the most likely diagnosis is heart failure secondary to hypertension.
Secondary to hypertension. Okay, fine, fine. So mention all the X-ray findings. So what can you see on this X-ray?
Okay, the X-ray findings, there is alveolar dilatation.
Okay, alveolar edema, you mean to say alveolar edema. What else?
Alveolar edema, yes, sir. And there is appearance of the Kelly-V lines.
Yes. Not so obvious on this view, but it's fine. What
Also,
else?
Then there is cardiomegaly.
Exactly. If nothing is apparent to you on this X-ray, cardiomegaly is so obvious.
Yes.
Okay. All right. So that's good. So list other
Yeah.
three clinical features of the diagnosis. What are the other things that you see in this patient?
Lower limbs edema.
Yes, one.
Lower
If you
limbs
examine
edema, okay.
the cardiovascular exam, what will you see on inspection, on palpation, and on auscultation? So start with inspection. What will you see on inspection?
Facial firmness.
What did you say?
Short of breath. The patient will be short of breath.
Yeah, so you say dyspneic. Patient is dyspneic. So how about when you palpate? You palpate and start with the pulse. What would the pulse be? What will it be like?
Shallow, rapid pulse.
Okay, so you say small volume pulse, small volume.
Yes. Small volume.
Small volume pulse. Yeah. So you may even have what we call pulsus alternans. So if the heart failure is very severe, you get pulsus alternans. What that means is that at this point, the pulse is very weak, and at another point, the pulse is very strong. So it's alternating between weak and strong pulses. Okay? So when you check the blood pressure for a patient with heart failure of this magnitude, look at the cardiomegaly. What do you think the BP will be like?
Very low.
Yeah, so the patient may have hypotension. If you go to the neck and check for jugular venous pressure, what will it be like?
There is raised JVP.
Yeah, so raise JVP, correct. So if you now go to the precordium and examine, what will happen to the apex bits?
There is a deviated apex bit.
So the word is displaced. Apex bit will become displaced. Yeah, displaced apex bits. So once you are done with the apex bits, if you now put your stethoscope and listen, well done. What will you hear?
Crepitation.
Yeah, so you can hear basal crepitation, but you are still on the precordium. So what would the heart sound be like? So you will hear S1, S2, S3. So because there is fluid congestion. So anytime when you have fluid overload in the heart, you have S3. When you have pressure overload, you have S4. So here you have S3. But when patient also has tachycardia. So when you have S3 with tachycardia, so we call that S3 gallop. Okay, so that's just taking you through how you go about cardiovascular examination and what you can see in the patient with heart failure. So can we list 3 causes of the above?
Okay, among the causes there is congenital heart disease.
Yes, but this is adult medicine. What else?
There's
Hypertension.
rheumatic valvular disease.
So yeah, so you initially said hypertension, so that should be the first answer. Hypertension. So the next thing that you now said, rheumatic heart disease or valvular heart disease, would then go as number 2. Okay, so
Thyrotoxicosis.
well, before you go to that, the next thing will now be cardiomyopathies. Cardiomyopathies.
Okay,
In
cardiomyopathies.
Nigeria, hypertension, valvular heart disease, cardiomyopathies. Yeah, well done. So cardiomyopathies, and then you can now start talking about ischemic heart disease and the rest. Okay. What drugs are used in the treatment of the above of the disease mentioned? So how will you treat this condition?
You have to give among the drugs there is diuretics, because you need to reduce the body fluids.
Yeah, so reduce the volume overload. Okay, what else?
There's digoxin.
Okay, so you can give digoxin, but well, we try and shy away from giving digoxin to patients, but it's fine. You can give digoxin to increase their injection fraction if their injection fraction is low. What else? So you can give ACE inhibitors. So even though their BP is low, you still have to give them maybe at least low dose ACE inhibitors. Because it helps. Yeah, so you give spironolactone. In fact, in UCH, if you come to the cardiology unit, there are 3 drugs that they like giving the patient. If the patient does not have money, anyway, if the patient has money, there are other bigger drugs. So for a poor patient, you just give RAT, R-A-T, ramipril, adactone, and torsemide. You can see ramipril is ACE inhibitor, adactone is mineralocorticoid antagonist, and T is what? Torsemide, which is a diuretics, a loop diuretics. Okay. So, next slide. I think this should be the last slide. Okay, one more. Anyone want to attempt this?
Sorry, sir, about the rat you mentioned, please, sir, the network was fluctuating. We couldn't get it.
Ramipril, which is ACE inhibitor. Adactone, which is also the same thing as spironolactone. And then the T is torsemide, which is a loop diuretic. It's stronger than furosemide, so that's why they prefer to use torsemide. All right, so who is attempting this question?
Okay.
Dr. Omulikoiri. Dr. Omulikoiri, I have not spoken today. Dr. Zara Adam. Okay, yeah.
Yes, sir.
So yes, can you attempt the question?
Yes.
So what's the likely diagnosis here?
Hyperthyroidism.
Yeah, likely secondary to what? A female with eyesight. So what can cause
Also,
hyperthyroidism in a female that has eyesight?
Graves' disease.
Exactly. So you say hyperthyroidism, likely secondary to Graves' disease. If you say that, you get your full mark. But if you just say hyperthyroidism, you'll probably get half mark. Okay. So B, describe 3 features.
Exophthalmos.
Yes.
There is goiter, swelling around the neck.
2. What else?
Biting palm.
Palm. You can't see the palm of this patient. So what can you see in this patient? That's what they're asking. No? So what else can you see?
I can only see 2 things.
How about the hair?
There is hair loss.
Exactly. So some form of alopecia. And of course, if you say that the patient has lost weight, nobody will also argue with you. You look at that neck, but that we may say that one is subjective. Okay. So list 3 relevant investigation. They have done 1 thyroid function test. So list other investigation that can be done in this patient.
X-ray.
Thyroid ultrasound.
Yes. So you do neck ultrasound to look at the thyroid gland. 1. What else? That's 1 out of 3.
You can do antibodies, thyroid antibodies.
Yes, also antibodies. Thyroid stimulating antibody. Okay.
Radioiodine uptake.
Exactly. Exactly. So those are the main things that you will do. So you can then do other ancillary investigations, but basically those 3 that you mentioned. Now, list 3 drugs that can be used in the management of this patient.
Abimazole.
Yes. What else?
Propranolol.
Yes.
PTU.
What else?
PTU.
Yeah. Okay. Which drug do you use in pregnancy? P
PTU.
for P. Exactly. Why won't you want to use carbimazole in pregnancy?
Teratogenic.
Teratogen.
So what will happen to the fetus if a pregnant woman uses carbimazole?
It's teratogenic.
I know, but what is the teratogenic effect? That's what I'm asking. What will happen to the baby?
Agranulocyte.
Well, that will be to the patient using it, but the patient can.
Congenital malformation. Okay.
I think we've lost Dr. Alimi. Maybe he's on a call. but this appears to be the last question. So we'll just give him a minute. If he doesn't return, okay, I can see he's trying to join. Let me accept him.
My network went off temporarily. I had to rejoin. So yeah, so I was asking that question. So that the answer to that question is aplasia cutis. Okay, just imagine the baby not having skin. So that's one of the teratogenic effects of carbimazole. So that's why I want to avoid it. One of the reasons why I want to avoid it in pregnancy. So I think this is the last slide. So do we have any questions? Question, concerns? I was thinking I was going to come for clinical examination, but unfortunately I didn't have time over the weekend. So I guess my other bosses have taken that part. So that's fine. So do you have questions for internal medicine?
Doctor, can you please show us that curly B lines again, please?
Okay. Can you, what I will do is, I'm not the one sharing the slide. So go back to that X-ray. Let me see. So the thing is, I may not be able to show because I'm not the one sharing the slide. So they are just horizontal lines. They are horizontal, how will I say it now? Infiltrates that you see that is abutting on the pleural. So you know where the pleural is now? The pleural is at the margin, very close to the rib. So when you see a line that is just moving perpendicular to that pleural, to the pleural, then that's the Kelly B lines. You also have Kelly A, Kelly C, but typically not failure. Kelly B line is what you should look about. So they are just form of interstitial edema essentially. So nothing really big about them. So, but if they are going to ask you anything about chest X-ray, the thing that you should probably take note of will be cardiomegaly, okay, like that other one where the lung, tension, pneumothorax, things that you don't need to strain your eye to see. Pleural effusion, you should know pleural, you should be able to identify pleural effusion on X-ray. And what else now? Pleural effusion, cardiomegaly. I will say that don't really bother yourself about Kelly B lines, but know about pleural effusion, know about cardiomegaly, and know about mass, and maybe a mass in the lungs. So those things essentially. The exam is probably an exam that a 400 level or 500 level student should pass. So nothing out of the blues. I know that things in Nigeria sometimes we make it difficult, but I think we are trying to make it as easy as possible over the last 2 years. Okay, and Med Tutors
Thank you.
is actually helping out to also ease our fear for the exams. Okay, so any other question? Any other question? So, all right, so in the absence of further question, I would like to thank you guys for having this interactive section. So, and I wish you guys all the best in the exam coming up this week. Okay, so all the best, everyone.
Thank you very much, Dr. Allen. We really appreciate.
Yes, sir.
So we take a 10 minutes break, then we'll continue. Thank you very much, everyone.